Hello and welcome all to this webinar today on monkeypox and how communications can prevent misinformation and stigma. My name is Wafa El-Sadr. I'm a professor of epidemiology and medicine at Columbia University, director of ICAP, and also director of Columbia World Projects. And I'm also a co-lead of New York City's Pandemic Response Institute, which is hosting this webinar today. Let me tell you a few words, something about the Pandemic Response Institute, or PRI. It's an initiative that was designed to help prepare New York City for future public health threats, whether that be from infectious diseases or climate-related health emergencies, and to do so by advancing racial equity and elevating New York City as a model of public health preparedness and effectiveness in responding to such health emergencies. The City of New York selected Columbia University to launch and operate the PRI with its key partner, the CUNY Graduate School of Health, Public Health and Health Policy, and several other community research and corporate partners. As you're all well aware, of course, we are now experiencing a global outbreak of monkeypox, and the World Health Organization, as well as actually New York State and a few other states, have declared this outbreak as a public health emergency of concern. This new outbreak is now resulting in cases being reported from over 70 countries around the world. And these countries have reported almost 24,000 new cases of monkeypox that are occurring outside the traditional endemic countries in West and Central Africa. And in the US alone, there has been already reports of large numbers of cases, as you are also aware. And many of these cases have been centered in several municipalities in this country. So this webinar builds on the one that the PRI sponsored a few weeks ago, which focused on the epidemiology of monkeypox. And you can access that webinar on the PRI website, and we can send you the link after this event. I'm now going to hand it over to my colleague, PRI co-lead and Dean of the City University School of Public Health and Public Policy, Dr. Ayman Al-Mohandes, to welcome you as well and to introduce our speakers and panelists. Ayman.
Thank you, Wafa. And with New York City being an international destination for tourism and business travel, and one of the regions most affected by the outbreak in the United States, many are focused on the current status of this emergency and its impact on the communities most affected. Unfortunately, monkeypox is yet another example of an infectious disease that could lend itself to the quick spread of misinformation, as well as stigmatization of demographic groups and communities. Our ability to deal with the spread early and effectively should not be deterred with misinformation and stigmatization that could disenfranchise victims and discourage them from seeking care. Concerted efforts to prevent and stem out any misinformation leading to unwarranted and unfair stigmatization is part and parcel of any effort to confront this new epidemic. Today's webinar starts with an update from the New York City Department of Health and Mental Hygiene on the current monkeypox outbreak, presented by Dr. Julian Watkins, known to many of you, the Health Equity Advisor to the Center for Health Equity and Community Wellness. And that will be followed by a brief question and answer segment. Then my dear colleague, Professor Bruce Lee, MD, MBA, and Chief Technology Officer for PRI and Professor of Health Policy and Management at CUNY School of Public Health, also serving as Executive Director of CATCH and a Senior Contributor to Forbes, will take us through how both the COVID-19 pandemic and the monkeypox outbreak have been accompanied by misinformation and stigmatization, and how we could better prevent these threats from happening now and in the future. We will conclude with a panel discussion on the challenges that misinformation and stigma have presented for communications during the health emergency. This will be facilitated by Dr. Lee, who will be joined by Sarit Golub, PhD, MPH, Professor of Psychology at Hunter College and the CUNY Graduate Center, and Donald R. Powell, MHS, Senior Director of Policy and Development, Exponents, Inc. Sharon Otterman, Metro reporter for the New York Times, and then we will also be rejoined by Dr. Watkins. Links to the speakers and panelists' bios are listed on our website. And now here's my colleague, Bruce Lee, who will be moderating the rest of this webinar. I'm sure we will all learn a great deal today. Thank you so much.
Well, thank you, Wafa and Ayman, and welcome to our speakers and panelists. The key goal of this webinar is not only to address the current monkeypox outbreak, but also to establish a framework and communication strategy for all future infectious disease threats. We're delighted to have Julian now provide an update on the monkeypox outbreak. So without further ado, I'd like to pass our virtual microphone to Julian.
Hello, I hope that everyone can hear me, and I hope that everyone's doing well today. My name is Dr. Julian L. Watkins. I work at the New York City Department of Health and Mental Hygiene. And I'll give a brief update on the monkeypox or MPV outbreak in New York City, and I'll hop right into it. So to start, the United States, the total outbreak in the United States, as of yesterday, the total number of cases reported is 5,811. As of last week, the United States actually surpassed Spain to become the nation with the largest number of monkeypox cases. In the United States, New York City is the jurisdiction with the largest number of cases, and we have over 1,500 cases as of diagnosed cases as of this morning. So I won't go into some of the background on monkeypox, but I think just talking a little bit about what we know about the spread. I think that we will learn more through investigation, through case investigations, as we learn more about this virus in this outbreak. But what we do know right now is that the direct contact with a rash or with someone who has sores or who's infected with the virus, we know that that is one of the primary means of transmission. We also know that folks can be infected with this virus through contact through clothing, bedding, or other porous materials. We also know that there is a component of a risk for transmission with the large respiratory droplets. We think that this mode of transmission is less effective and less contagious than COVID-19 or common influenza. It's not known at this moment if monkeypox can be spread through bodily fluids, including oral fluids, semen, or vaginal fluids. At this point, we know that a person is contagious from the time that their symptoms start until all sores, including scabs, have healed over and there's a fresh layer of skin that's been formed. This can take up to 2 to 4 weeks. So who is at risk? I think it's important to say that anyone of any sexual orientation or gender identity can be infected with monkeypox, and there is increased risk. With this increasing spread of monkeypox in the general community, we really do want to emphasize that anyone can get it. But what we do know that as time goes on, more cases will be reported as testing is more available and more widespread, and there's a more awareness of this virus. But we do know that there are some limits to testing right now. We have limited testing capacity, but we also know that these sores or rash can present or look like other types of sores or rashes, which may delay diagnosis. And we also know that not everyone has access to medical care. I'm acknowledging some of the vulnerabilities that we have in our city. But currently, cases in the United States and in other countries are showing that the virus is spreading most in social circles and the networks of folks who identify as gay, bisexual, and other men who have sex with men. So who should get vaccinated? So right now there's one approved vaccine that's being used for the vaccination program for this outbreak. That's the Jynneos vaccine. It's been approved by the FDA for people ages 18 and older. We're not recommending generalized vaccination against monkeypox at this time for the general public, but we are focusing vaccination for folks who may have been recently exposed, something called post-exposure prophylaxis. People who've been identified as a close contact to someone, or who is suspected to have someone who is known to have or suspected to have had monkeypox, they'll be contacted through the New York City Department of Health and Mental Hygiene through our contact tracing, and they'll be offered vaccination. We are also offering vaccination for folks who may have had a recent exposure at our monkeypox vaccination clinics and sites. So there are multiple vaccination clinics and sites around the city. Appointments are being scheduled. Appointments are being released on a rolling basis due to the low supply of vaccines that are available. Some good news is that it was announced last week that some 800,000 vaccine doses will be made available across the United States, and we expect that New York City will receive a large portion. So hopefully, a lot more vaccination appointments will open pretty soon. Right now, we have 4 city clinics at our sexual health clinics in that network at the Chelsea site, Central Harlem, and Corona, and also there's a site at the Health and Hospitals Vanderbilt site. There have been other pop-ups, and we hope to, once the supply is increased, that we can set up additional modes and ways that folks can get vaccinated. Vaccines are free and will be available for folks regardless of their immigration status or their insurance status. And we really are encouraging folks to check our website at nyc.gov health/monkeypox for updates. Check regularly because we've actually updated some things, and I'll share that on the next slide. After this slide. So the current eligibility for the vaccines are based on the following criteria. Number 1, gay, bisexual, or other man, cis or trans who has sex with men, or other folks who identify as transgender, gender nonconforming, or gender non-binary. Folks who are 18 and older, and the folks have to meet all 3 of these criteria. And finally, folks who have had multiple or anonymous sexual partners in the last 14 days. Folks should consider getting vaccinated if their partners have shown signs of signs or symptoms of possible monkeypox infection. If folks have met recent partners online or through social networking platforms such as Grindr, Tinder, Scruff, or some of the other ones out there, or at local meeting spaces that are on the screen. And also we're encouraging folks who may have medical conditions that may put them at increased risk for severe disease if infected with monkeypox. So we know that folks living with HIV or other conditions that may weaken the immune system. We also know that some folks with some chronic skin conditions may also be at risk for severe infection. So what to do if folks have symptoms? Call your provider right away. If you don't have a provider, calling 311 and checking out the NYC Health Map is an option for folks to go by to seek evaluation and treatment. If folks do suspect that they may be infected with monkeypox, they should avoid all close physical contact with folks until they've been checked out from a provider. Folks should stay at home or isolate, something that most of us are pretty familiar with after the last 2 years, and separate from folks living in the household. If folks must leave the house for medical care or essential needs, it's really important to cover active lesions with clothing and to wear a face mask to reduce respiratory spread. And then assist when someone from the health department inevitably calls you and asks about your contacts. We encourage folks to actually engage in contact tracing, one of a very old tool in our public health toolkit to help stop spread. So the city is doing a lot to try to address this. I think really importantly, on July 30th, the city of New York declared the monkeypox outbreak public health emergency. Hopefully that will make a lot more resources available, and that the city can take urgent action to contain the spread of this virus. We're providing guidance to support healthcare providers and assisting them with screening and diagnosis. We're helping to expand testing in the city. We're doing case investigations, contact tracing, reaching out to identified contacts. We're offering post-exposure prophylaxis for those who've been recently exposed, providing information, doing a lot of community outreach with our partners, doing a media campaign. We're doing a lot of the good work, and also connecting with press and elected officials to disseminate fact-based, non-stigmatizing messaging to New Yorkers. So what can you do if you think that you were exposed? Again, going to the New York City Department of Health website, you can actually sign up for text alerts. I signed up a couple weeks ago, and you get they'll update you with vital information. There's palm cards that are available on our website that folks can share. There's also the CDC has really good information that's really affirming, that kind of covers a lot of the frequently asked questions. Sharing accurate information. We'll get into the discussion later about misinformation and disinformation. And try whatever we can do to destigmatize this. Anyone can get it, can get this thing. Even though we are seeing this that this disease is spreading more frequently in certain communities, we know that all communities can be vulnerable if we don't contain the spread. And for folks to learn about symptoms and to help folks find care if they are sick. Just sharing that the health department has recently updated our monkeypox data page. I encourage folks to go and look at it. The data includes information on confirmed and probable cases in New York City. The new data page also shows some charts if folks are into graphics and into the numbers. And we kind of break it down by race and ethnicity and gender and sexual orientation, so we can kind of get a little bit more disaggregated in the data. And then for the final slide, this is a picture of some of the palm cards that we're handing out in the community with the QR code for folks if they want to learn more, and just encouraging folks to, you can call 311 and actually order some physical copies of the palm cards. I'll stop there and I'll pass it to Dr. Bruce. Thank you.
Thank you, Dr. Watkins. So people have been asking questions throughout. So if you have questions, feel free to post them in YouTube or the YouTube chat, et cetera. We're going to try to get to all of the questions that we can. So some of the questions that you've posted, we might save until the panel because they might be more appropriate there. So kicking off, the first question for Dr. Watkins is, many people are saying that health providers are refusing to test them because they aren't LGBTQ plus and multiple partnered. Thoughts and advice?
I think that it's, it kind of is very specific based on what your risk factors and what would make someone request testing. When we see that things, make it in the news, I think that there is a higher awareness of something. This is still, even though this is an emergency and we do know that this is spreading, a lot of other common things are common. So I think it's if some of your exposures are similar to what I shared in the presentation, if you have met anonymous sex partners, if you do have a lot of contact or social networks in the LGBT community where it's currently the most spread, I think it's an ongoing conversation. But if you want a second opinion, there are other options in the city as well. If you truly do believe that that this could be monkeypox.
Thanks, Julian. Another question is about the Jynneos vaccine. So one is, is there an effectiveness rate available? And they're asking both for preventative use and for post-exposure prophylaxis, which basically means, after you've been exposed, what's the effectiveness in either preventing the illness or reducing the illness?
So that's a bit harder to suss out. This vaccine was most recently authorized for use against monkeypox, and also currently we're using because of the very limited supply. We're in New York City, following some of the guidance of other jurisdictions. We're actually doing a 1-dose regimen. The full vaccination course for Jynneos is 2 doses. So some of that efficacy data is not available currently, but we do believe and know that there is some protection. But I think some of that will be revealed with time.
Okay, thanks. Another question is, how do you define quote unquote close physical contact?
I think that close physical contact is, well, It's a great question. And I think close physical contact is really, skin to skin contact. What we're seeing is from some of the case investigations internationally and even in the United States, we've seen that a lot of folks have gotten them in certain places where crowded, cramped conditions. A lot of folks were in places where clothing may have been optional, or so close physical contact, meaning skin to skin contact, prolonged. We don't think that this is something that can be spread through, a casual handshake, or like touching a doorknob or brushing against someone. We think this close physical contact, one of the closest forms of physical contact is sexual contact, and so I think that's why we're seeing spread through that mode of transmission is most common. But there's multiple ways that multiple things that can reach the definition of close physical contact.
Okay, thanks, Julian. We'll do one more question before we proceed to the next segment of this webinar. And again, I want to emphasize, if you have questions, keep asking them. We'll try to collect them, and we can answer during the panel discussion as well. So the last question for this segment is, how are different states and countries working together to control the spread of the virus across borders? Any collaboration or measures in place at airports or border systems?
I am not aware of any measures at border systems or at airports. I will say that the scope of my work is New York City based, and we don't have any, airport, checks, no temperature checks, no skin checks right now. But hopefully what we will see with the declaration from the World Health Organization and other nations making these declarations, I think that a global outbreak response with a lot of collaboration will be really important. I think that the spread of this virus in the West, in Europe and the United States, just really highlights the importance of vaccine equity in a global sense.
Okay, thanks, Julian. So again, if you sorry that we couldn't get to all the questions, but we are saving them up. So if you have additional questions for Dr. Watkins or the rest of us throughout the rest of the webinar, keep asking them. We're going to try to save them up, and we'll try to address them during the panel. So thanks again for your questions. And now thanks again, Dr. Watkins, for the update. That was very helpful. It's always great to hear what's going on with the New York City Health Department, which is central to this response to the outbreak. So with that, I'm going to move on to the second part of our webinar, which is basically going through some of the misinformation, disinformation that's really emerged during this outbreak, as well as the stigma that has arisen, unfortunately, that's been part of this outbreak. And unfortunately, this is not new. Unfortunately, this is something that we've seen throughout many other types of infectious disease outbreaks, epidemics, pandemics, or basically when any type of infectious disease has come onto the scene. So, as you mentioned, the title of this webinar is How Communications Can Prevent Misinformation and Stigma. And communications is really central to the response to any type of infectious disease threat. So, as you'll see. So when we talk about stigma, this is something that public health experts and authorities have been worried about, for a while. And that really prompted earlier in this past decade, the World Health Organization to come up with guidelines in terms of how to name new infectious disease threats, how to name new illnesses. Because as many of you know previously, many times infectious diseases were attached to the names of particular towns or particular groups of people or particular countries. The problem with that is it's not as if the different groups of people or different communities and the towns and the countries came up with those names for themselves. Many times those names were attached by other people. So in other words, a given community didn't say, oh, let's name this virus after ourselves, because how many communities really want to do that? So we were in a situation where other people were naming viruses and bacteria and different pathogens for certain people, for certain countries, et cetera. And you can see how that can be a problem. And so that was supposed to help alleviate or prevent the stigmatization. And when we talk about stigmatization, it means, bringing unwanted and unwarranted negative attention to particular groups, demographics, or communities. And we also know that misinformation has been a problem throughout a lot of history. I mean, we may be more aware of it now just because there's been more easier spread through social media or through the 24/7 television cycle and things like that. But even before the COVID-19 pandemic, there's plenty of misinformation out there. And here are some of the misinformation that I covered before 2019, including suggestions that you should snort sugar, or that basically you should ignore very standard public health advice. Yet once again, during the COVID-19 pandemic, misinformation has been rampant. So we've seen all of this throughout the COVID-19 pandemic, ranging from claims that the COVID-19 vaccines can alter your genes and make you grow extra parts on your body, to ideas that there are microchips being injected, to unauthorized medications being used that have no scientific basis. So that's been a problem throughout the COVID-19 pandemic. And unfortunately, so has stigmatization of certain demographics and communities, for instance, Asian Americans. And I covered these through Forbes as well, where basically you started seeing rises in anti-Asian hate and violence and all those types of things. Now, one thing to keep in mind is the pandemic didn't really create these new sentiments. It basically uncovered what was already existing. So we heard about how COVID-19 worsened a lot of existing disparities, but the same thing is true with stigmatization. I wrote for the Milken Institute Power of Ideas that really, there was this underlying sort of anti-Asian American sentiment, for instance, for many years, but people were just not aware of it. And the COVID-19 pandemic really exposed it. So that brings us to the monkeypox outbreak. So monkeypox is not a new virus. Unlike the COVID-19 coronavirus or SARS-CoV-2, the monkeypox virus has been known and around for a while. And it was first discovered in a lab, and it got its name monkeypox, not because it's particularly associated with monkeys, not because monkeys are the primary host, but they happened to find it in monkeys that were in a laboratory. So it was just that, and that's how it got its name. And unfortunately, that name stuck because no one decided to rename it. And the first human case was identified in 1970, as you can see on this timeline. And then since then, there's been some outbreaks, and those outbreaks have been, they happen to be in certain countries in Africa simply because some of the animals that are probably carrying the virus and maybe serving as the reservoirs, like rope squirrels, happen to be in those areas. It had nothing specifically to do with the people or the communities in those areas, but that just happened to be. You can go to any place in the world and you can find particular pathogens that happen to be in geographic area. And we've had our first ever monkeypox outbreak back in 2003. And then it remains sort of this outbreak disease where you see cases here and there, scattered, many times just individual cases, until this year. This is the first year we've really seen such an extensive outbreak. And it really started in May 2022 when there was cases identified in the UK, the United Kingdom, as indicated in its timeline. And eventually, it started spreading to many, many different countries. And it was declared a public health emergency of international concern on July 23rd. And over the past couple of months, that's when the United States really started doing the testing and the vaccination. And then now it's an emergency in New York, as well as California. So moving right along, its transmission mechanisms have been known for a long time. It's basically, as Dr. Watkins indicated, it's close contact. And that close contact can be close physical contact where you're actually touching people's lesions, or touching any type of body fluid that may have the virus, or it can be transmitted via contaminated objects, such as blankets, beddings, clothes, or large respiratory droplets. So when you're closer than 6 feet. So these aren't the kind of the aerosolized droplets that you talk about with the COVID-19 coronavirus, but it's really closer contact, and it's more extended contact. So this has been known for a while, and it's really, that was quite established until this year. But once again, there's been misinformation and disinformation. Difference between misinformation and disinformation is disinformation is when it's deliberate. Misinformation may be accidental, but disinformation can be deliberate. And basically, this includes things like, claims that Bill Gates has released this monkeypox as a bioterrorist, and Alex Jones suggesting that the monkeypox outbreak is due to COVID-19 vaccines, and other types of suggestions. Again, these are not backed by evidence whatsoever. And the concern is that these are agenda driven. So it's not just accidental misinformation, but there's deliberate political and business agendas behind spreading this misinformation. And again, we've also had stigmatization of certain groups. And again, the concern is a lot of these may be politically agenda driven. So it's not just random misinformation. Sometimes it's actually active disinformation. So of course, you can't tell until unless you jump in the minds of the people who are actually spreading the misinformation. But one example is, recently there was the discussion that there's been at least a couple cases of monkeypox illness in children in the United States. And Dr. Rochelle Walensky, the CDC director, mentioned that on a live stream. And then immediately that was questioned, say, oh, well, if it's appears in children, yet it's a sexually transmitted infection, why is that? And then, question mark. And then there's also, recently efforts to rename monkeypox after, very questionable and in many cases insulting terminology. So one has to question, how much of that is actually agenda-driven disinformation, which is even a bigger problem because you're talking about an actual strategy behind spreading this misinformation. So we have to remember that the monkeypox virus does not, and I repeat, does not discriminate based on race and other demographics. It's not as if the virus sits there and says, oh, I'm going to selectively infect someone of a certain race, a certain ethnicity, a certain background, a certain sexual orientation. That's absolutely not true. And one of the concerns is that when you start seeing these pictures of people of certain demographics, people start associating particular demographics with those diseases. That's why the Foreign Press Association of Africa said, please stop showing pictures of very specific demographics, like people of African descent having monkeypox. If you look at the overall outbreak, it's affected many different people of different demographics. So it should not be associated with a single demographic. The other issue, and as I alluded to, was this belief that's been spread that monkeypox is exclusively a sexually transmitted infection. Monkeypox is not the same as gonorrhea. It's not the same as chlamydia. It's not the same as other infections, sexually transmitted infections that are exclusively transmitted via sex, via exchange of bodily fluids during different types of sex. Here we're talking about a virus that can spread via close physical contact. And that can be any type of close physical contact, like if you happen to be a caregiver for someone, or you happen to be in the same apartment or roommates or what have you. Now, it is true that some of these studies, as I highlighted here on the slide, have found monkeypox DNA, virus DNA in seminal fluids or saliva, those things like that. So that just shows that it's potentially in different bodily fluids. That does not necessarily mean it's really being transmitted through those bodily fluids, but it raises concerns that there's all types of bodily fluids where the virus may appear. So that does not mean that it's a sexually transmitted infection. Again, repeat. So instead, monkeypox really spreads via close social networks, any close social network. So one of the issues right now is we're seeing more cases in among men who have sex with men, but that might be just a social network effect, because if a case appears in someone, then that person may be more likely to spread it to whomever that person happens to associate closely with, like a friend, a family, some type of colleague or some type of coworker. And basically, and again, I want to emphasize close physical contact. It has to be extended close physical contact. So then, if this had started in any other group, then it could be like associated with that group as well. So we need to back away and emphasize and remember the biological nature of this virus. It just happened to spread more extensively within one particular social network, but it shouldn't be just associated with that social network. The concern is, again, we've seen the stigmatization that it's really, this is exclusively within the gay community, or this is associated with people of African descent, or things like that. And then similarly with the COVID-19, that, somehow this is associated with people of Asian descent or what have you. What ends up happening is already marginalized groups are further stigmatized. You don't see situations where groups which are have a strong authority or power or have particular advantages in the society get stigmatized. It really happens to groups that are already marginalized. They already are facing problems. They're already facing discrimination, things like that. So again, if you look at the groups that have been affected by COVID-19 and the monkeypox outbreak stigmatization, they're all marginalized groups. And that's really unfortunate because adding additional burden on groups that are in communities that already face an unfair burden. And the other problem, in addition to, obviously that leads to, emotional distress, psychological stress, and a lot of problems. No one wants to be stigmatized. It also actually inhibits and interferes with proper response to outbreaks, epidemics, or any type of infectious disease threat. So first of all, people don't take the infectious disease threat seriously because they think, oh, okay, I'm not part of this quote unquote risk group, therefore I don't have to take precautions. That's absolutely not true. Like you can't sit there and say, oh, just because I'm not of a certain race or ethnic group or of a certain sexual orientation, et cetera, that I don't have to worry about COVID-19 or don't have to worry about. That's just not true. You have to worry about any type of close contact with someone who may be infected. There are potentially delays in case identification because you may be looking for the wrong place. You might say, okay, well, this demographic, it's not likely they're not a at-risk group, therefore I'm not even going to look for cases in this group. Or someone who's infected and they don't want stigma to be brought upon them. They don't want to be in a situation where they feel that they'll be treated unfairly. They may be less likely to seek healthcare and therefore get identified. And then there's other issues in terms of the actual collecting data and figuring out who's actually being infected. You shouldn't just focus on particular groups and collect data among those groups. You have to really see where the virus is spreading just in general. And that can really affect the interventions and policies, such as, for instance, vaccine distribution. So, do you just vaccinate certain groups or certain communities? Or do you say instead, let's look at all the contacts. So for instance, since this is not exclusively an illness for particular sexual orientations, we have to look at all sexual orientations. They may all be susceptible, and maybe we might be in a situation where they need to be vaccinated. So you really have to look at contacts and contact networks besides these particular demographics. So it's causing a lot of problems with the response. And the problem is many times this public health communications can be reactive rather than proactive. In other words, now we're seeing stigmata. Now we're seeing a lot of the misinformation, and sometimes the horse has left the barn, so to speak, and it's tough to bring back that misinformation. So this cartoon just says, well, you don't wait until a fire to say, maybe I should have paid the water bill. So, and if we look at it, businesses, for instance, they always have a communication strategy, or usually always have a communication strategy whenever they launch any type of product and service, and it can be way in advance of that product and service launch. So you can think about like whenever Apple launches a product, they have this long-term communication strategy, or whenever they drop movie trailers long before the movie actually gets released, and all these kind of arriving soon announcements. The strategy is already in place and it's already developed long before the project gets launched. So why can't we do the same thing in public health? Well, one of the reasons is there just hasn't been enough investment in such communication for public health. You've probably heard that the budgets for public health are very, very, very low. There's little money to do anything. So we as a society really have to start investing further into this type of communication strategy. We don't want to say let's double your budget if your budget's already zero. So with that, here's one possible framework for approaching communications whenever you have any type of infectious disease threat. And it can be like a threat just to a few people, or a threat as an outbreak or a epidemic or even a pandemic. So we use the acronyms SPARE. So SPARE. So if you look at the S stands for scan or survey the origins of the outbreak. So we have to keep in mind communication is essential to integrating everything. So you say, okay, where did this outbreak or where did this epidemic, where did it first emerge? Not who it's caused by, because where it first emerged is not necessarily who it's caused by. So like in the monkeypox outbreak, we know that it's monkeypox has been seen in the past in certain countries in Africa. Then we have to ask ourselves, okay, we have to be worried about stigmata, stigmatizing people who are African descent. And if it happens to spread in the MSM community, we have to be careful about stigmata towards that community and do everything to proactively avoid that. So you want to scan and survey, and then you want to preemptively really determine, so the P stands for preemptively, determine who or what groups may be stigmatized and the systems involved. And we have to remember, these are very complex. So you have to look at who's connected, get to know the different communities and determine how misinformation may spread, how stigmata may spread, and really kind of come up with a game plan on how you're actually going to counteract this. And that's A, which is, activate. And you actively, proactively put in measures using a systems approach. And basically you want to use a systems approach, meaning you have to look at, what are the complex dynamics. Otherwise, you're going to have band-aids rather than solutions. You might actually have unintended consequences, worsening existing disparities, waste time and effort, and you may actually introduce bias. So you have to be aware of the complex dynamics of what's actually happening. And then R stands for re-emphasize the biology, the science behind the outbreak. So for instance, maybe you want to vaccinate based on geographic activity of the virus and contact networks rather than, very specific demographic groups. Because again, it's not specific to any type of sexual orientation. It's not specific to any type of demographic. It's really a product of close social networks and contacts, those things like that. And finally, E, you want to engage the communities that may be affected by stigmatization. And engagement does not mean talk down to, and doesn't mean one-sided communications. It means actively involving diverse communities in decision-making and say, okay, hey, come on, we're trying to join the table. We're trying to generate a response to this outbreak, to this epidemic, to this pandemic. What are your concerns? How do you think we should proceed with this? What are your fears? How do we engage the different communities? And with that, you really can better combat misinformation and stigma. This is basically just a summary slide that these are historical problems, ongoing concerns with infectious diseases. It's happened now, it's happened in the past. Unless we change what we do, it's going to happen in the future again. So it's really important. Communications is really central. As the previous slides showed, you really want a situation where you integrate things such as data collection. You want to integrate that with the actual intervention and policies and response. You want to integrate that with the communities, with the different stakeholders. Communications is the glue. That's why we think it's really important to establish these new types of communication strategies way in advance. Again, I want to emphasize that this is already being done in many other sectors. This is already being done in the business sector. So we have situations where products and services are unveiled and you already have a communications plan way in advance. And so all of these things really need to work together and they need to be heavily integrated. And so, the SPARE acronym reminds us what we actually need to do. We have to scan the situation and we have to say, okay, who might be affected by stigma? What kind of misinformation may be generated? What kind of disinformation may be generated? And more importantly, who might have what particular agendas and how do you actually combat that? Because it's one thing to combat just random misinformation. That's easier. You can be in situations that, okay, let's just try to make sure everyone knows what's going on. But if there's active disinformation out there, active disinformation for political reasons, for political gain, et cetera, that's harder to combat without any type of established strategy. And you want to proactively really determine, what kind of misinformation will be spread, and then you want to activate different types of policies and interventions and a communication strategy to combat and contain this misinformation and stigmata. And then you want to re-emphasize the science. It's all about the science, to re-emphasize the science. Even if it's the same thing over and over again, you want to re-emphasize. And finally, you really want to engage different communities because they need to be part of the decision-making. We can't have a situation where it's top down and you say, okay, the communities are here, the decision makers are separate. those communities then might be concerned that there is, okay, what's going on? What is your agenda as well? So with that, just wanted to credit our FICOR team, which helped put together a lot of this information. We've been in the field of pandemics, epidemics, outbreaks for the past 15 years, and have been doing a lot of computer modeling and communications work around the area. And so certainly happy to answer any questions and address any issues or any concerns right now or going forward. So with that, I'd like to segue over to our panel, where we're going to really dive a little deeper into a lot of the information that we've covered with Dr. Watkins' presentation and the Q&A, as well as some of this information about misinformation, disinformation, and really how to combat this. So I'm going to stop sharing my presentation and we can dive into the panel. And again, I want to emphasize, if you have any questions, please drop them in the YouTube chat. We're happy to address questions. We want to make this as interactive as possible, meaning that we want to field the questions and really discuss this amongst our panel. And also, we're also happy to address these questions going forward. So maybe we can convene back so that we can see all of our panelists. Okay, so I know we've had a little bit about time before Ayman introduced all of you. So why don't we do just basically a one-line reintroduction so that everyone is reminded of who you are. So we are very fortunate to have this distinguished panel. So Donald, do you want to start off and just introducing yourself?
Good afternoon, everyone. My name is Donald Powell. My pronouns are he, him, and his. I serve as the Senior Director of Programs and Development here at Exponents, which is a recovery community organization that supports the quality of life of individuals managing HIV and other chronic illnesses, works with individuals who have been traumatized through engagement in the carceral system, as well as individuals with persons who utilize drugs or are in recovery. And just very briefly, I've been involved in this process through my own personal connection to the community and my challenge is getting a vaccination myself.
Thanks, Donald. And Julian, do you want to reintroduce yourself?
Yeah, sure. I'm Julian, an internal medicine trained doctor, public servant, and I think about health equity as a work of justice. And I have, from the communities that I came from, have a lot of work to do to make things right and to make things better.
Thanks, Julian. And Sharon?
My name is Sharon Otterman. I cover healthcare and the pandemic for the New York Times on the Metro desk.
Thanks, Sharon. And Sarit?
Hi, my name is Sarit Ghalib. I'm a professor of psychology at Hunter College and the Graduate Center here at CUNY. And a lot of my work tries to translate findings from psychology into community engaged communication, especially about sexual health. Okay,
thank you. So let's start off with a question that actually is a quote unquote leftover, and I won't mean leftover in a bad way, but leftover from the previous session that we couldn't get to. And that's the question about the renaming of monkeypox. So someone had a question of what the status of that is right now. And maybe Julian, you can take this question. And then that also just translates to a larger question in terms of, what are the issues or is the situation with the naming of this virus and this disease?
So I guess with renaming, the World Health Organization has called to rename and locally the Commissioner of Health. I think the mayor of New York City has also come out to rename the virus. And I think it goes with, I guess, we kind of know why some of the dangers of stigmatization with the African continent and a lot of, anti-Black sentiment and, some really old retrograde things that can lead to modern day stigmatization. And so, yeah, there's the call to push But I think the other stigmatization that you mentioned earlier, Bruce, around some of the bad actors trying to stigmatize the communities affected and trying to, get personal and political gain out of stigmatizing the lives and the social networks of folks who identify as queer.
Thanks, Julian. So, one question I had was, this is a continuing question, and this is directly mainly to Sharon, but certainly happy to hear others' thoughts. So there's a challenge in communicating. We always hear that simple messages are easier, right? And it's difficult to communicate complexity. But these are inherently complex situations with outbreaks and epidemics. So Sharon, what are your thoughts about this challenge behind communicating something that's complex, inherently complex, but trying to get the word out, especially since you have so much experience covering pandemics and epidemics and are continuing to cover, COVID-19 and the monkeypox outbreak. What are your thoughts about that, and what do you think are some best practices?
I think with any journalist, once you start to engage in a topic, you forget that a lot of people still don't know even the first thing about it. At the times, one way that they're trying to address that is to kind of have these explainer pieces, which kind of break down frequently asked questions about something like really technically difficult, like understanding monkeypox, alongside the news, because my job isn't to just keep repeating the same thing, but to constantly be moving the ball forward with new information. With this, it is very clear that this is primarily spreading through sexual contact. And so we can't downplay that. As a matter of fact, there's been a little bit of like a pushback within the queer gay community themselves, saying we can't just forget how this is spreading, because that's leaving people vulnerable and not, but because they can't protect themselves. And so, we can't like wish away that fact because of fear of stigma. So it's a balancing act to really explain, yes, sexual contact is, the primary way that this appears to be spreading right now, probably because of the sort of contact and the mucosal membranes involved and which are just more susceptible to spread. And so that's, difficult. And it's always disheartening to read the comments to your stories, because you realize that sometimes what you were trying to say is not actually what the readers were reading, but we just try to do it again the next day.
Yeah, sometimes they're very simple messages where people, I believe, and some of the comments in some of your articles, like, oh, well, just don't have sex or something of that sort, some simple response like that, right?
Yeah, I think speaking for the readers, and again, a lot of these webinars are for people, again, who are already in this community or interested in the subject. That leaves out this vast other group of people who know nothing about it and don't want to know, or just have heard something tangentially. But there's a lot of confusion around monkeypox. Hey, COVID just happened. How come I had to wear a mask? How come I had to cancel my wedding? How come I couldn't visit my grandmother? But now this new virus is here affecting a certain community, and why can't we tell that community to change their behavior? There's a lot. I just changed my behavior for COVID. And so there's this huge disconnect between these two groups of people, which, as you said before, is just sort of underscoring, whatever it is, homophobia, whatever it is, the disconnects that already existed before. And it's just being amplified by yet another thing. How come this community isn't being told what they should be doing when I had to be told what I was doing in a pandemic, that just happened?
So complex dynamics with a lot of these communities, even between different communities. So Donald, what are your thoughts in terms of striking this balance between complexity and simple messaging, but also understanding that there needs to be different types of responses, and helping people be aware of prevention strategies and those things like that?
So before I respond to that, I just want to kind of open this up, because I continue to hear that monkeypox is sexually transmitted. I'm under the impression that the belief is that it's skin to skin, and because of the prolonged exposure during sex, that's what creates the heightened potential for transmission. And I think for me, that's a big piece of this. extrapolating the fact that it is the prolonged contact during sex that makes people susceptible, not the sex itself. Once again, I think that continues to stigmatize gay and trans communities. I think it has challenges. As somebody who's been enrolling people in vaccination appointments, you get to a question in there and ask people about 14-day partners. And oftentimes what you'll get is a pushback to this, because we went through this with HIV. HIV was laid squarely at the door of the gay community. And so, you know, for 30, 40 years, we've been trying to live that down. So now here comes this thing. And I think the messaging has to be really clear that we're not clear that this is sexually transmitted. What we know is that it is an increased exposure because of the prolonged exposure during sex. The other thing that I think is really important, we talk about queer communities, and I don't think we give enough credence or underscore the importance of intersectionality. So yes, there is a large queer community, but within that, there are Black queer folk, and there are Latino queer folk, and there are immigrant queer folk, and there are queer folk who utilize drugs. And so what are the implications for, one, getting that information out to them, but also kind of ensuring that we're not just talking about availability, we're talking about accessibility. So those are just a couple of things I want us to kind of open up the conversation around. But the other thing that I'll say very quickly is, in this process for me, I think one of the things that I'm not hearing is how important community is to getting this information out. One of the things that I was able to do when I was getting vaccine appointments, I utilized a young man from Ballroom, and he literally referred about 25 individuals to me who needed vaccination appointments, including himself. And then what he did last weekend is he went live while he was getting his vaccination. And he talked clearly about the fact that there's a little pain, it's a sting, it's this, it's that. So people got to see exactly what was going on. The final thing that I'll say here is, I think we need to take a page out of Brené Brown and lead from vulnerability. I think there's so much about this virus we don't know, and we tend not to, we shy away from that. We shy away from the fact that we don't know what is the efficacy of the vaccination. We shy away from the fact that while this is a 2-shot regimen, we're not clear when people are going to get the second shot. So there are all these uncertainties. And I think when we don't talk about those things, it fuels distrust, particularly in communities of color.
Thanks, Donald. I mean, very important points that you emphasized there. Including the fact that, you're really dealing with a lot more heterogeneity in different communities, that we tend to sit there and assume that, oh, this is one big box of people, whereas it's actually really a lot more complex than that. So Sharit, there's a question in the from the audience that I think would be great for you to address, and certainly, of course, welcome other comments. But the question is, the impact of stigma, but also what specific interventions that have been studied and demonstrated have demonstrated effectiveness that might be of use in this type of situation, or other situations in general.
So I can answer that, but I feel like I also need to sort of weigh in on some of the other pieces that have been put out there so far. And one sort of big frame that I would love for us to think about and talk about within this conversation is the different goals of different types of messaging. And I'll connect it back to the stigma, because I think that stigma is manifest differently in those different channels. And so one channel is the channel that Sharon, you asked Sharon about, which is basically the journalism channel that's outside of public health. Obviously, it's intended to distill, as she said, to précis public health information, but it isn't part of a public health agenda or a public health strategy. That agenda is the agenda of journalism, which sells newspapers, among other things. In terms of our thinking about like the agendas of public health, we have a responsibility to educate our public we have a responsibility to try to engage them in programs that we are trying to implement. And we have a responsibility to, I think, create communication that is designed to act trustworthy. And so I think that a couple of I think that this is a false dichotomy between like compelling or easy and true in some ways. And I think that messaging in each of these channels needs to reinforce individuals' intelligence, agency, and dignity. And if you ask me what the most important communication, anti-stigma communication strategies are, it's messaging that reinforces intelligence, agency, and dignity. People can understand complicated things as long as they are clear. I think that we get into a lot of problems within public health because we haven't been transparent. We often do not tell people the why behind the different messages that we're giving or the different interventions that are available. And I will give sort of, we have a lot of data in psychology and also evidence from COVID that when we talk down to people, when we tell them what they can't do and what they shouldn't do, it engenders reactance. We also have a tremendous amount of data that fear-based messaging is effective for a very short period of time. And so overall, we need to focus on telling people what they can do, how they can benefit themselves, but again, within the context of building trust. And I'll just give one like very specific information that I'd love to hear folks talk about. So right now, I heard from the earlier presentation that we are not recommending vaccination to the general public. My understanding, and I'd love to know whether or not I'm right, is the reason that we are not recommending vaccination to the general public is, first of all, because we don't have enough vaccine. And second of all, because many people in the general public are not likely to be exposed. But the why behind that message, I feel, is not getting out. And I think that if we're able to make those types of messages, people can understand them better. To answer that other question about what stigma reduction interventions work, very briefly, they're interventions that stop the use of us, them, or they, them language. They are interventions that normalize, especially sexual behavior and sexual health as an overall part of health, wellness, and well-being. And they are messages that reduce the use of risk-based language, which we have not seen. I actually think that the CDC does a tremendously amazing ability to not use risk-based language, but a lot of other folks that we've seen have it.
Thanks, Dorit. Julian, I wanted to give you an opportunity to respond about the vaccines. I know that there's also a question from the audience about the availability and the decisions on like who should actually get the vaccine.
Yeah, I mean, that's correct. I think, unfortunately, there's a very low supply and there's a really high demand. And I think the bigger issue that we have seen is that we know the communities that are marginalized by an active process of marginalization, where even when the vaccines are available, we saw the images, of the lines in Harlem, in other parts of the city that are primarily minority populations, but we see, folks who don't live there getting this very limited, health preserving, possibly life-saving intervention. And so we know that if there are not guardrails put on the availability of these things, people will do what they can do to get the thing. And, and as Sarit said, folks who probably will not be as exposed. And we also just understand also that the availability of some of these interventions, I'm just de-emphasizing vaccines, just knowing that that we cannot get out of this with a purely biomedical approach. I think that really addressing some of these social determinants of health and really looking at what we can do to help communities, support communities, get folks access to care, get folks sick leave. All of these things are really important for us to address these things. And as part of the whole plan, if we just primarily focused on biomedical, we'll end up in a place where we are right now with HIV, where in New York City, we follow our own trends for HIV transmission, where globally, where nationally, it's the communities that are most infected with HIV, Black MSM, Hispanic, Latinx MSM, and white MSM. But in New York City, that has shifted in the last 2 years. Now, Black MSM, Hispanic, Latinx MSM, and Black women who have sex with men, heterosexual Black women, are actually being diagnosed with HIV at higher rates than white MSM. And we see it because of, we're seeing it's because of people don't have access. We see segregated access to healthcare. We see that certain communities that are at risk continue to be underestimated. People don't think about them. People don't consider them. And I think, in closing, I think when we talk about, medical racism, stigmatization, and all of marginalization, I think a lot of folks think of it as this, malicious malintent that people are doing things to, put their neck on the, put their foot on the neck of communities. But this other, more prominent, more real issue is the fact that a lot of communities are not even being considered, right? It's marginalization by omission, by a lack of consideration, where we see rollouts and things happen and we don't even think about the most marginalized, the people who could use the most, who have the most barriers to care. And then we find ourselves in this, in this strange loop where we see similar patterns playing out across all these disease processes. When we have certain communities, it always falls down on certain communities. And then we see this, and then as public health and medicine, when those communities don't have any trust in us, we look at them as if they're crazy, as if their lived experience, as if what they see and experience is not real. And I think that's another bit that we have to acknowledge and adjust, because these communities, the communities that I come from, the communities that I represent when I'm in my meetings and when I'm in these spaces right here, people aren't meeting our standards. And it takes elevating the work that we do as public health and medicine and all of these fields to elevate our standards, right? To improve our work, to raise our standards, to meet the standards of people who are discerning, who actually have a really good take on the world, and who can actually determine and interpret a lot of the things that are going on in this world in a way that a lot of folks couldn't even imagine or wouldn't even consider. And I'll stop there.
Thanks, Julian. A key point there that main times marginalization is omission, that people don't even talk about a community as opposed to actively stigmatizing a community. Any responses or any other thoughts? So here's a question from the audience. It's about this declaration of a state of emergency. The question is, what can be inferred when considering that our local government has declared a state of emergency? I guess this has multiple implications. So one is, maybe Julian, if you could mention what that means, and then if anyone else in the panel could discuss, how does that affect communication of some of this outbreak, and how do you think, what's the impact of declaring something an emergency?
I think it's really important because it hasn't been done very often. I think this is the 6th time it's been done since the World Health Organization has even has been declaring certain things public health crises. And I think on a very hyper local level in New York City, I think this declaration can open channels for the health department to, to take further actions. I think a declaration at the federal level can make all of the cases be mandated to be sent, mandatable or reportable, to kind of be sent to the CDC so that the numbers are aligned and so we can have a better idea of what's going on. I think it may also free up resources on the federal level if that declaration is made, to get resources to local communities, as we saw with the declaration for COVID. In those early days of COVID, very same, people don't want to say rationing, but tests were being funneled through public health systems and to try to decide who can get tested or not. So I think it just really allows us to respond with some rapidity. But I think the other bit that I think is important too, the declaration of an emergency, I think is important for communities to recognize, if my government and my city is taking this serious, then I think it will help folks also kind of take it more serious too. And I think it's unfair to ask a community to take something serious and change their whole life around if the city or the government, the federal government itself won't even acknowledge that this is a big emergency. So I think there's a lot of things that this adds, and I think it's a very necessary step as we move into a new phase of this response.
Donald.
So I just wanted to mention a couple of things to follow up what Julian was mentioning. I think it's really important for us to look at this through an equity lens. I think so often we talk about availability and we don't necessarily talk or shine the light on accessibility. I know when I went for my appointment, and I'm a 30-year-old veteran doing this work in public health, I had to call around to numerous colleagues to get a vaccination appointment for myself. And what I saw in the Central Harlem Sexual Health Clinic on 137th and 5th Avenue was one man who appeared to be Latino, an additional man who looked to be of African descent, and 15 other individuals who would look to be Caucasian. I then balanced that with the fact that early on when we heard about monkeypox, the first thing I heard was that Northwell was working with Suffolk County to open up not one, not two, but 6 pop-up vaccination sites on Fire Island. What that says to me is a lack of equity. And I think, Julian talked about kind of this rolling out to other populations. I think one of the things we need to learn some lessons from COVID. Early on in COVID, the mandate was if you've traveled to Italy, if you've traveled to Europe, you should get a test. Then we found out that these folk who were in grocery stores and in laundromats, because they came in contact, were susceptible. So I think now about, yes, it seems to be concentrated in queer and trans communities, but what about those individuals who oftentimes look like me, who are working in restaurants, who are working in hotels and coming in contact with bedding? How do we figure out how to protect those? And why is that not a consideration now? I think oftentimes and I understand public health strategy says concentrate on the pool of the infectious pool, but I think oftentimes we wait too late to kind of look at some other stuff. And what that does is it reinforces in communities of color the fact that I don't matter. When I turn on the TV and I see this picture around monkeypox on all the news stations in front of the Chelsea Sexual Health Clinic, and I see all these Caucasian men milling around, that sends an implicit message to me that this isn't accessible to me. So I think there's work we need to do in our own systems, and I know we're doing some of it, but I think we need to do it a lot quicker.
Thanks, Donald. Important points. And that's something that we want to definitely get back to. Sharon, I wanted your thoughts about the emergency question, and Donald, we also want to pivot back to this equity issue. How does that change reporting at the New York Times or in journalism when something's declared an emergency? Does that have a significant impact? And also, what about the question of now we've got 2 emergencies? We've got the COVID-19 and monkeypox.
Yeah, so the state and the city have declared states of emergency over this. The governor's declaration was more specific. She's trying to free up more people to be able to give vaccines. And she's also trying to make vaccinations reportable, because if you're an adult in New York State, you do not have to report a vaccination. You have an option not to report it. So this is going to make a vaccination mandatory reporting, so we can have a better sense of who is actually getting vaccinated in the state. The city declared a state of emergency. They didn't really say exactly why they were doing it. We know that when you declare a state of emergency, you get to go, skirt regular procedures when it comes to hiring people, spending money. It also gives you more access to sort of federal funds and other funds. So we are hoping that what that means is an influx of resources to fight monkeypox. The city, often talks about how it doesn't control the vaccines. That's true. But there is a lot that the city can do. For example, I find it, like this problem of all the white people waiting online for the vaccines. Well, that was a city rollout. So that the city is making efforts to try to improve that. The city could also provide support, for example, to people who have to isolate for 2 to 4 weeks. I mean, that's a huge equity question. How do you have somebody who's living paycheck to paycheck supposed to stay home for 2 to 4 weeks? We did have a hotel program for COVID. Perhaps we could find some way to support people who are sick with monkeypox. So, hopefully it releases a lot of funds and resources to help support people who have monkeypox and prevent monkeypox. In terms of reporting, A lot of times these declarations are declarations. So that, the newspapers, we're interested in declaration, but what we really want to see is, what does it mean? What actions is going to happen? Is this the start of a new strategy? Are we going to be more aggressive? So for us, we want to see like what it actually means to declare a state of emergency, not just say it's an emergency.
And to follow up, and I wanted to jump to Sarit, who I'm sure has lots to add to these issues. But so Donald mentioned, the equity issue, the representation issue, even like going to how people are represented in photos and who's represented in photos. What are some of the strategies from a science communication standpoint do you think are important to consider where there may be inadvertent implications of inequity and further disparities? What are some of the strategies to combat this from a communication standpoint?
Is that to me? We have gotten a lot of pushback actually for showing these lines of people. If you look at the comments in our stories, every time we show a line of people waiting for vaccinations, we do get pushback. Why are you showing these people? It's interesting. Part of it is for stigma. Part of it is just a concern for privacy. As Sarit mentioned, that the newspapers are not necessarily part of a public health strategy, although we are one of your strongest tools. For example, we had a front page story that really highlighted the excruciating pain that monkeypox sufferers were going through. And, prior to that, there was kind of an impression among a lot of people that it was mild. So why are we worrying about it? And so, it's very important we can give visibility to issues that can be hard to give visibility to. And also we rely on, people in the community to speak out. And this community has been amazing in sacrificing their privacy, and coming forward. And these are hard-learned lessons from other health crises where people are willing to humanize this issue. And that makes a tremendous difference in terms of public understanding of the issues. But our agenda is slightly different from a public health agenda. In other words, we are trying to give visibility to issues, but it's it's the public health job, to actually make sure that everything's happening on the actual response.
Thanks, Sharon. It's always helpful to get the journalist perspective, which many times I think public health folks don't always see. I mean, they interact, but they don't always see that perspective. Sarit, wanted to give you an opportunity to chime in.
Yeah, sure. I wanted to lift up something that I saw as one of the questions, which is, how do you strike a balance when communicating to healthcare staff who are exhausted and burnt out already by COVID? And I think, and then declaring this emergency, I think that's a real experience that is happening right now. And I think that we need to talk about it. I think that our messaging is only as good as the content that is behind it. And we can't solve a content problem with better messaging. And I think that one of our big communications challenges right now is that we're trying to use individual behavior change, or we're trying to message around individual behavior change to actually solve a systems level problem. That so much of our messaging is focused on what individual people who might be exposed to MPV might need to do, and that it's somehow their responsibility to stem the tide of this epidemic. And I think that is a wrong-headed sort of approach. I think that we have evidence that MPV surged in large part because of our system's failure to address an endemic problem that we've known about for years. And more important to that, and more related to this emergency issue, is it surged because we weren't able to scale up testing, treatment, and vaccines quickly and broadly enough. And we're still not able, we still don't have that capacity. And these are systems level behavior problems. And we need investment in public health infrastructure. And even more importantly, we need to pay and value our public health workforce and our providers in a way that makes them want to stay in their jobs. We are literally hemorrhaging healthcare staff and public health workers right now. And I think that that is a message that needs to be propagated and needs to have emergency funds and actual support thrown at. And the messaging to like sort of get back to like, what do we communicate to our healthcare staff? We need to communicate to them that they are going to receive support that they need, and the information to them needs to be incredibly useful and needs to be backed up by resources like access to treatment for their patients, access to where they send their patients for testing, and access to how exactly they should evaluate a patient for a particular case or for a potential exposure. And I think that the same idea about trust and transparency and accountability is what, and agency and dignity for our healthcare workers is what we need as well within this state of emergency.
Thank you for that.
Julian, did you have anything to add for that?
No, I was saying thank you. I think it's a true crisis that's not being talked about.
Yeah, certainly. So we basically have the pandemic, which has been going on for 2.5 years, and now we have an additional burden on top of everything that's already going on with healthcare. So certainly important issues. Another question is, how do we distinguish between reasonable fear and irrational panic? Some are becoming very frightened. Are regular folks expected to determine for themselves whether to seek vaccination or other measures?
So I just want to chime in here very quickly and say language is important. What are regular folk? I think there's a concern, and language is so powerful in terms of either bringing people in or excluding folks. So I think it's really important for us to have really, really expansive conversations about this. I was talking to a colleague of mine who runs Bronx Mobile, which is outreach to persons who inject drugs in the Bronx. One of the things that I hadn't even thought about, for individuals who inject drugs and who get lesions or sores, those sores look very similar to monkeypox lesions. How will they know the difference? If an individual from that community has monkeypox, where do they isolate? Can they isolate if they have a habit that says I have to get high every day? So we haven't had those kinds of conversations. I think we really need to open this up and continue to look at the micro communities of queer and trans individuals, and then think outside of it. And I'll just leave you with this very quickly. About a year ago, the city declared a state of emergency around racism. I think if there's a way to collapse that declaration with this one, we could potentially do something to really hold up equity in ways that make information, testing, and vaccination accessible to everyone.
Thanks, Donald. Very important points. We are about 7 minutes to go. We have about 7 minutes to go in the webinar. Wanted to catch some of these questions that seem to be bundled because they're asking about similar things. So it seems like there are a number of questions about the actual transmission, and so about touching someone's clothing, the path and entry point of the virus into the body, household transmission. Who's looking at household transmission? So I wanted to give you, Julian, you an opportunity to respond to some of these questions.
So we think the primary transmission is like prolonged or repeated exposure to intact skin, but we do know that folks who may have like chronic inflammatory skin issues or broken skin, that it can be easier to transmit. But I think one of the other bits, and I think that one of the modes that this people who are being infected as a result of sexual intercourse, there's the mucosal surfaces, so the pink parts, in our mouths and in other parts of our bodies, which are a lot more prone to transmission of of viruses. It's not as those mucosal surfaces are not as thick as the epidermis or the outside layers of skin. Those are the main ones. And then finally, we do think it can be inhaled through an exposure of these large respiratory droplets. And again, we think about COVID. COVID COVID is a respiratory droplet. That's like the 6 feet away type kind of thing. But that's why we're just encouraging folks to wear masks if they're known to have monkeypox, or if folks are concerned, that's something that folks can do to kind of reduce their personal risk.
Okay, thanks, Jillian. So with about 5 minutes left, I want to give each of our panelists a chance to mention any of the or respond to the questions that have been mentioned, or bring up anything which you feel will be important to bring up, around this topic. We're always we always run into situations where there are more questions and more things to talk about than time. But wanted to give each of you an opportunity to leave some of your closing thoughts. So in no particular order, it's just based on who I happen to see. Sarit, do you want to offer some closing comments?
Sure. And I saw a bunch of stuff in the sort of comments as well about back to your idea of like how we can counter misinformation. And I would say sort of two things about this. One is really going hard, I think, as a public health community and as folks in general on recognizing and embracing sexual health as an overall part of health and well-being, and not segregating sexual health care, sexually related forms of transmission from into this other. The other big thing that I think is important for us to recognize is that from a psychological perspective, a lot of times stigma comes from individuals' desire to distance themselves from those people who have a particular illness because we're afraid of getting it. And so we try to create something that means that those people are going to get it, but I'm not. And we try to create that distance as a self-preservation measure. And part of that is why a lot of times fear messaging actually fuels this us them approach, because it fuels that desire and that need to be afraid and to create that us them. And I think that the other thing that fuels that is that here in the United States, we do not have the belief and the experience that healthcare is a right, and that having access to the things that we need to live healthy lives are a right, and therefore we'd better keep it in our camp because there isn't enough to go around. And so I think that fundamentally focusing on health equity, as Donald said, but health equity not just within this particular outbreak, a right to universal health care and health equity more broadly is a way to combat stigma, both in this epidemic, but across epidemics in general, and keeping in mind that fear-based messaging fuels stigma.
Thanks, Sarit. Very important points. Donald, I wanted to give you an opportunity to issue some closing comments.
So I just want to echo what Dr. Golub said, and I think it's really important that we also realize people aren't sometimes just distancing themselves from the disease, but against the stigma that's attached to it. So I don't want to be identified with HIV. I don't want to be identified with monkeypox, because that means that I may be associated with a community that is already stigmatized. And as somebody who's Black, as somebody who's a woman, as somebody who's transgender, I'm already feeling all of that stuff. I always tell people, if you think about privilege and protection, there's no one who comes to mind quicker than white, cisgendered, heterosexual men. I think if you look at the continuum, the further you get away from that, the less access, the less protection you have. I think there's no coincidence that trans women of color have some of the poorest health outcomes around, because they are so far away from our notion of what privilege and protection look like. So I think that's really, really important. The other thing that I will say is, it's so important for us to tap into our community. I think I just want to lift Dr. Watkins up as a man of African descent to be here, to be in the New York City Health Department and to be propagating these messages out, because oftentimes people tend to associate the message with the messenger. So the fact that we have public health individuals who look like us, who understand the context of our lives, the context of the stigma and the shame that we've oftentimes had to live through, I think that will increase public health outcomes. Thank you.
Thank you, Donald. Very powerful words. Sharon.
First of all, I just want to thank the members of the community for being brave, coming forward to tell their stories, and that is, I think, one of the most powerful ways to combat stigma is through humanizing the people who are going through any particular problem. I think that I'm hoping that the public and the public health, we can get at least, I know we talked about simple and complex messages, but we do want to say monkeypox can infect anyone, but right now it's primarily affecting the community of people or the social networks of men who have sex with men. I think both of those messages are really important to get out there. And I think that if it's done properly, if we don't take care of this now, if we don't throw a lot of resources at it, then it is going to be in many more communities, in many more places. And we don't want that to happen. And so I feel like we can, understand the message with, that two-part message. And that, I think that the public can deal with that message.
Thanks, Sharon. Important advice and suggestions. Julian, do you have any additional words?
I think the final takeaway, is, I think we talk about misinformation as if it's a newer kind of concept or even something of modernity. But I think in actuality, misinformation is one of the oldest tools, political tools that has been used and employed in this country. And I think the oldest bit of misinformation that nobody talks about is the misinformation and the lie, the pathology of white supremacy. And it's the way it manifests in our society and how much we have lost and sacrificed as a society to maintaining this misinformation, this disinformation. We've dedicated so much of our public health energy to prove it. So many of the founders of medicine were white supremacists and put so much of their intellect and their time to prove it. And I think we've sacrificed so much, and we continue to sacrifice so much because we've set up a society where a hierarchical system based on your skin tone and your hair texture determines your worth. And look at what we've sacrificed. We can't even, as public health and as medicine, and address a new emergent virus in a way that can help everyone. We've rendered ourselves, ineffective in effective communication. And I think that's the big sacrifice. That's what we have to talk about. There's some deep work that we have to do, but we can only do it together because, again, that we've been divided and conquered to make it seem that we're not even in the same community together. And we are all part of this bigger community. And we are, all of us alive in 2022, we are living in a very important, moment on the timeline of the world, and our species. And I think a lot of what we do going forward will be the future of our world and the future of our species determined on what's going on with us around today. And we have a moral responsibility to hold many truths at once, to hold the facts, but we have a moral responsibility to do this work, to undo these things. We cannot continue the same path forward or else we're going to get the same results. And the truth of it is white supremacy and all of that is killing people of color, but it's killing white people too, and it's destroying this world. And so I think that's my takeaway. We have a lot of work to do.
Thanks, Julian. Those are great words to leave us by. So once again, I wanted to thank all the panelists and all the speakers today, as well as the audience for joining our webinar on stigma, communications, and monkeypox. We've really seen how this misinformation stigmatization has hindered a response to infectious diseases in the past with COVID-19 and again with monkeypox. And we've tried to outline some of the future solutions to prevent this from continuing to happen now and in the future. As New York City and the US continue to be affected by COVID-19 and monkeypox, it is clear that we must take new paths to address disease outbreaks to protect our health in our communities. So I wanted to say thank you to, again, everyone you've seen on the webinar, but including folks that you haven't seen who really were pivotal to put together this webinar. Dr. Danielle Green, Executive Director of State and Local Public Health Initiatives at CUNY SPH, and the Chief Operating Officer at CUNY for the PRI. Bashar McKay, PRI Senior Communications Officer at Columbia. Mitch Stripling, who's the Director of the Pandemic Response to the PRI with ICAP at Columbia, and Sienna Pratt, who's a CUNY SPH research assistant and doctoral student, for their hard work to make this webinar happen for us today. Also, thanks to Sarah Rebert, Communications Director for FICOR and Catch, who's helped a lot with the presentation. This is just the first event and initiative from the PRI communications team that's led by Chris Palmetto and Scott Radson, who are faculty at CUNY SPH. I encourage today's attendees to check out the PRI website and to follow us on social media and with the handle at the NYC PRI to be in the know regarding future PRI events. Many thanks and have a great rest of your afternoon.